Welcome to this video entitled Diabetes Mellitus. Diabetes mellitus is the term used to represent a clinically and genetically heterogeneous group of disorders characterized by abnormally high blood glucose levels, that is hyperglycemia, as a result of either insulin deficiency or cellular resistance to the action of insulin. Four major classifications of diabetes have been defined. Type 1 diabetes mellitus, formerly known as insulin-dependent diabetes mellitus. Type 2 diabetes mellitus, formerly known as non-insulin-dependent diabetes mellitus, gestational diabetes mellitus, and diabetes secondary to other conditions, e.g., hormonal abnormalities and pancreatic diseases. According to the Centers for Disease Control and Prevention, according to the CDC in 2008, there are more than 24 million people with diabetes in the United States. Of this number, 90% to 95% have type 2 diabetes. Additionally, there is another 57 million who have a condition called pre-diabetes, according to the CDC in 2008. The National Institute of Diabetes and Digestive and Kidney Diseases and the American Diabetes Association, ADA, found that diabetes was the seventh leading cause of death in the United States in 2006. Overall, the risk of death among people with diabetes is approximately twice that of people without diabetes. The annual medical costs for diabetes in the United States in 2007 were $174 billion in direct and indirect costs. This is a 32% increase in the overall dollar amount spent on all aspects of diabetes care, according to Diabetes Statistics in 2007. Next we will discuss the causes of diabetes mellitus. Type 1 diabetes mellitus is thought to be an autoimmune disease in which pancreatic beta cells are destroyed. The beta cells are responsible for secreting insulin, a major hormone that promotes cellular uptake and use of glucose and maintains metabolic functions throughout the body. If the beta cells are destroyed, the pancreas produces no insulin, causing glucose levels in the blood to skyrocket. Onset can occur at any time, but most patients are younger than age 30. Although type 1 diabetes mellitus is one of the most common chronic diseases in children, its etiology remains unclear. Suggested etiologies include genetic predisposition to the destruction of beta cells, infection, autoimmunity, and environmental factors. Viral agents are highly suspected in the pathogenesis of type 1 diabetes mellitus, because mumps, rubella, varicella, measles, influenza, Coxsackie virus, cytomegalovirus, and viral pneumonia have been reported to precede its onset. Furthermore, the incidence increases in the United States during the fall and winter, when viral infections are prevalent. Autoimmunity is evident because 80% of patients with type 1 diabetes mellitus test positive for specific human leukocyte antigen. It is likely that a combination of these factors contributes to the destruction of beta cells and the subsequent absence of insulin. In type 2 diabetes mellitus, adipose and muscle cells become less sensitive to the actions of insulin, or the pancreas produces less insulin than the body needs. In either situation, glucose levels in the blood escalate. Most patients with type 2 diabetes mellitus are older than age 30. Box 45.1 lists risk factors for type 2 diabetes mellitus. The major risk factors are obesity and family history. Both beta cell defects and insulin resistance are found in patients with type 2 diabetes mellitus. In gestational diabetes, pregnancy causes the woman to become intolerant to glucose. The causes are not fully clear. but they appear to be related to the anti-insulin effects created by progesterone, cortisol, and human placental lactogen. Usually, once the woman has delivered her infant, blood glucose levels return to normal. However, women who have had gestational diabetes have a 20% to 50% chance of developing diabetes in the next 5 to 10 years. Pause the video and carefully scrutinize box 45.1 summarizing major risk factors for type 2 diabetes mellitus before proceeding to the next slide. We will now discuss the pathophysiology of diabetes mellitus. In type 1 diabetes mellitus, the pancreatic beta cells are destroyed, causing a subsequent absence of insulin. In genetically susceptible people, an autoimmune attack occurs in which monocytes or macrophages and activated cytotoxic T cells infiltrate the islets. Multiple antibodies against beta cell antigens develop in the blood, and insulin reserve steadily decreases until the amount is insufficient to maintain a normal blood glucose level. The pathogenesis of type 2 diabetes mellitus involves insulin resistance, impaired insulin secretion, elevated glucose production by the liver, or all these components. With insulin resistance, circulating insulin concentrations increase as compensation. Researchers have hypothesized that in type 2 diabetes mellitus, the ability of insulin to inhibit hepatic glucose production and to stimulate its uptake and use by adipose and muscle cells is diminished. In lean patients with type 2 diabetes mellitus, the primary defect appears to occur in the beta cells. In overweight patients, who represent most patients with type 2 diabetes mellitus, the most likely primary defect is impairment of the target cells. Although abnormal hepatic glucose metabolism plays an important role in maintaining the diabetic state, it is probably not the earliest development and most likely follows impaired insulin sensitivity in the muscle. Insulin affects many body systems, and chronic hyperinsulinemia contributes to the pathogenesis and worsening of hypertension, dyslipidemia, and coronary heart disease. Hypertension, high plasma triglyceride levels, and low high-density lipoprotein, abbreviated as HDL, plasma levels correlate with hyperinsulinemia secondary to insulin resistance and a worsened cardiovascular risk profile. This collection of clinical markers or indicators associated with insulin resistance is referred to as metabolic syndrome. Epidemiologic and interventional studies consistently point to the relationship between good glycemic control and the prevention or slowing of the progression of long-term complications of diabetes. The Diabetes Control and Complications Trial, abbreviated as DCCT, presented definitive evidence to support the hypothesis that diabetic complications are related to the degree of hyperglycemia. In this landmark study, patients with type 1 diabetes mellitus were randomized to 2 groups and followed for an average of 6.5 years. One group received conventional therapy, 1 or 2 daily insulin injections, daily self-monitoring of glucose, and diabetes education, to normalize blood glucose levels. The other group received intensive therapy, 3 or more daily administrations of insulin and glucose monitoring 4 times daily. The incidence of microvascular complications was 60% lower in the group that received intensive therapy than in the patients who received conventional therapy. Hence, intensive therapy delayed the onset of complications and slowed their progression. The United Kingdom Prospective Diabetes Study, abbreviated as UKPDS, group answered the question as to whether the DCCT results could be extrapolated to include type 2 diabetes mellitus. In the UKPDS, Patients with type 2 diabetes mellitus were randomized to intensive or conventional therapy and followed over a 10-year period. As in the DCCT, there was a significant, that is 25%, risk reduction in microvascular endpoints with tight control. Next we will discuss the diagnostic criteria of diabetes mellitus. Patients with marked hyperglycemia present with the classic symptoms of polyuria, that is excessive urination, polydipsia, that is increased thirst, weight loss, polyphagia, that is increased hunger and caloric intake, and blurred vision. In type 1 diabetes mellitus, the onset of these symptoms usually is sudden and often preceded by ketoacidosis. In contrast, the course of development for type 2 diabetes mellitus is gradual, insidious, and frequently undiagnosed for years. The onset and sometimes the presence of symptoms often go unnoticed. Therefore, screening for diabetes as part of a routine medical examination is appropriate if a patient has one or more risk factors. See box 45.1. The more risk factors that the individual has, the greater the chances are for him or her to develop or have diabetes mellitus. Because early detection and prompt treatment may reduce the impact of diabetes and its complications, screening is recommended for those at risk. The new consensus for diagnosis includes use of hemoglobin A1c, abbreviated as HbA1c. Fasting plasma glucose, abbreviated as FPG, can also be used. Less often the oral glucose tolerance test, OGTT, is employed. Diagnosis can also be made on presentation with classic overt signs and symptoms of diabetes. Fasting plasma glucose and now the HbA1c are generally the easiest and least expensive diagnostic tests. Fasting is defined as no intake of food or beverage other than water for at least 8 hours before testing. The oral glucose tolerance test is still the preferred test for pregnant women, and it can be performed in either a one-step or two-step method. The key with pregnant women is careful risk assessment in the early stages of pregnancy regarding their risk of diabetes mellitus. Normal glucose is defined as a fasting plasma glucose level of below 100 mg per deciliter and a 2-hour postload glucose, abbreviated as PG, value in the oral glucose tolerance test of less than 140 mg per deciliter. A normal HbA1c is 4% to 6% and can be obtained regardless of the last oral intake. Those who test higher than or equal to 6.5% should have repeat testing to confirm the diagnosis. A fasting plasma glucose level of 126 mg per deciliter or more or a 2-hour postload glucose value in the oral glucose tolerance test of 200 mg per deciliter or more warrants repeat testing on a different day to confirm the diagnosis. Patients with a fasting plasma glucose of at least 100 mg per deciliter, but less than 126 mg per deciliter have impaired fasting glucose, abbreviated as IFG. Patients with a 2-hour postload glucose value of at least 140 mg per deciliter, but less than below 200 mg per deciliter in the oral glucose tolerance test are considered as having impaired glucose tolerance, abbreviated as IGT. Patients with impaired fasting glucose or impaired glucose tolerance are now referred to as having pre-diabetes, indicating the relatively high risk of developing diabetes. Diagnostic criteria are presented in Table 45.1. Plasma glucose levels can be obtained from patients regardless of the time the patients last ate. Such levels are referred to as random plasma glucose levels. Any random plasma glucose level of 200 mg per deciliter or more is considered positive for diabetes mellitus and warrants additional testing, preferably by the fasting plasma glucose test on another day. Certain drugs may cause hyperglycemia. These include glucocorticoids, furosemide, thiazide diuretics, products containing estrogen, beta blockers, and nicotinic acid. Pause the video and carefully scrutinize Table 45.1 summarizing the criteria for the diagnosis of diabetes mellitus before proceeding to the next slide. Initiating drug therapy. Effective treatment programs for diabetes mellitus require comprehensive training in self-management, ongoing support from the clinical care team, and, for many, intensive pharmacologic regimens. These programs must be individualized according to each patient's needs and should include the following features. 1. Self-monitoring blood glucose, abbreviated as SMBG. 2. Medical nutrition therapy. 3. Regular exercise. 4. Drug therapy individualized for each patient. 5. Oral glucose-lowering agents for some patients with type 2 diabetes mellitus. 6. Instruction in the prevention and treatment of acute and chronic complications, including hypoglycemia. 7. Continuing patient education and support. And 8. Periodic assessment of treatment goals. Treatment of abnormal glucose levels consists of diet and exercise. The cornerstone of therapy for all patients with diabetes is diet, but the goals of therapy differ between types 1 and 2 diabetes mellitus. In general, patients with type 1 diabetes mellitus are usually thin and present at or below ideal body weight. Therefore, the goals of diet are directed toward regulation of caloric intake and proper spacing of meals and snacks. In the presence of exogenously administered insulin, these patients require proper timing of meals and routine activities to prevent episodes of hypoglycemia. Patients taking insulin should carry a source of simple sugar at all times in the event of hypoglycemia. Because most patients with type 2 diabetes mellitus are overweight, the goal of treatment is directed toward weight reduction. Weight loss leads to improved glucose tolerance by enhancing the sensitivity of peripheral glucose receptors. Patients with type 2 diabetes mellitus can control the condition through diet and exercise alone. If these interventions fail to achieve desirable glycemic control, practitioners should initiate drug therapy. Next we will look at the goals of drug therapy. The major goals of drug therapy in diabetes mellitus are as follows: aglycemic control. 1. H.B. A1C level equal to or less than 6.9%, preferably equal to or less than 6.5%. 2. Preprandial plasma glucose level 90 to 130 mg per deciliter. 3. Postprandial plasma glucose level below 180 mg per deciliter. B. Blood pressure. 1. Less than 130 systolic 80 diastolic, and 125 systolic 75 diastolic for patients with proteinuria. C. Lipids. 1. Low-density lipoprotein, LDL, level below 100 mg per deciliter. 2. Triglyceride level below 150 mg per deciliter. 3. HDL level greater than 40 mg per deciliter. D. Microalbumin, random collection. 1. Less than 30 mg per milliliter creatinine. In type 1 diabetes mellitus, insulin is the mainstay of drug therapy. When diet and exercise alone do not achieve glycemic control of type 2 diabetes mellitus, drug therapy is indicated. In type 2 diabetes mellitus, oral agents with glucose-lowering effects are used. The ADA suggests that pharmacologic therapy be selected with consideration to the following factors. 1. Degree of hyperglycemia and the presence or absence of symptoms. 2. Presence of comorbidity. 3. Patient motivation. And 4. Patient preference. Table 45.2 provides an overview of the various oral agents. Let's now focus on sulfonylureas. Sulfonylureas are a major group of oral hypoglycemic agents used to treat type 2 diabetes mellitus. See Table 45.2. They correct derangements of carbohydrate, lipid, and protein metabolism. We will now discuss the mechanism of action of sulfonylureas. Sulfonylureas bind to specific receptors on beta cells, causing adenosine triphosphate, ATP, dependent potassium channels to close. The calcium channels subsequently open, leading to increased cytoplasmic calcium, which stimulates the release of insulin. Theorists have hypothesized that these drugs also have extrapancreatic effects involving the liver, muscle, and adipose cells, but because these agents are ineffective in patients with type 1 diabetes mellitus, it appears that their predominant hypoglycemic action is on the beta cells. When used alone, these agents have the most significant effect on blood sugar, especially in patients who are lean and insulinopenic. Sulfonylureas are divided into first and second generation agents. Second generation drugs are more potent and more widely used than first generation agents. Comparison of these drugs by potency and other pharmacologic properties is presented in Table 45.3. Approximately one-third of patients with type 2 diabetes mellitus fail to respond adequately to sulfonylureas, most often because of markedly impaired beta cell function, not adhering to diet, or stressful events such as infection. After 10 years of therapy, only 50% of initial responders have adequate glycemic control. For optimal response, careful patient selection should include the following criteria: duration of disease less than 5 years, no history of prior insulin therapy or good glycemic control on less than 40 units per day of insulin, close to normal body weight, and fasting plasma glucose less than 180 mg per deciliter. Let's now look at adverse events, contraindications or interactions of sulfonylureas. The most important complication of the use of sulfonylureas is hypoglycemia. In the elderly population, this risk is greatest secondary to comorbidity, polypharmacy, or poor social situations, e.g., isolation, or financial constraints. In younger patients, hypoglycemia may be associated with alcohol abuse or overexertion. Long-acting agents, e.g., chlorpropamide, marketed as Diabetes, place elderly patients with other underlying disorders at risk for prolonged and sometimes fatal hypoglycemic episodes. Drugs with active metabolites also may increase the risk of hypoglycemia in patients with impaired renal function. Hence, patient education must include recognition of symptoms as well as prevention and treatment plans for hypoglycemia. Sulfonylureas can cause weight gain of about 2 to 3 kg. They cannot be used in patients with sulfur allergies. Pause the video and carefully scrutinize Table 45.2, which is an overview of oral anti-diabetic agents, before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.2, which is an overview of oral anti-diabetic agents, before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.2, which is an overview of oral anti-diabetic agents, before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.3 summarizing the comparison of oral sulfonylureas before proceeding to the next slide. Next we will discuss biguanades. Biguanades are oral hypoglycemics used in conjunction with diet as first-line monotherapy or in combination with other classes of diabetic drugs, including insulin, to treat type 2 diabetes mellitus. See Table 45.2. Their mechanisms of action and side effect profiles differ from those of sulfonylureas, offering notable advantages. Biguanades do not cause hypoglycemia when used as monotherapy, and do not promote hyperinsulinemia or weight gain. Next we will discuss mechanism of action of biguanades. This class inhibits hepatic glucose production and moderately improves peripheral sensitivity to insulin. Gluconeogenesis and glycogenolysis are inhibited in the liver. Glycemic control is achieved without stimulating insulin secretion, so hypoglycemia does not develop. Other advantages of biguanades over sulfonylureas include their tendency to induce weight loss and promote favorable effects on lipid profiles. In addition, in certain patients, biguanades can be combined effectively with sulfonylureas, thiazolidinedins, abbreviated as TZDs, or insulin because their mechanisms of action differ. Biguanades are the agents of choice in patients who exhibit secondary failure to sulfonylureas. In view of their many beneficial effects, biguanades appear to be a more rational choice than sulfonylureas for first-line therapy in patients with newly diagnosed type 2 diabetes mellitus. Metformin, marketed as glucophage, is the only available biguanade. There is now a combination of glyburide and metformin, marketed as glucovance, and glipizide and metformin, marketed as metaglip, available. Metformin is also now available in liquid form, marketed as Riomet. Next we will look at the dosage of metformin. The dose is started low and increased weekly as needed to the maximum. Patients usually take the medication before meals in the morning and evening. The dose is carefully titrated in elderly patients. With metformin, the starting dose is 500 mg twice a day with increases every 1 to 2 weeks to a maximum of 2,550 mg per day. Peak action is within 2 to 2.5 hours, and the effects last for 10 to 16 hours. Steady-state levels of the drug are achieved in 24 to 48 hours. Metformin also comes in an extended-release formula. It is started at 500 mg daily with the evening meal and increased to a maximum of 2,000 mg daily. And now let's discuss the contraindications for metformin use. Contraindications include renal dysfunction, serum creatinine level of 1.4 mg per deciliter or higher, heart failure, and pregnancy. This class also is contraindicated in children, alcoholics, binge drinkers, those over age 80, and those with dehydration. Patients must stop taking metformin when undergoing radiologic studies with iodinated contrast, when experiencing metabolic acidosis, and before surgery until they resume normal oral intake. Next we will discuss the adverse events and interactions of metformin. The most common side effect of metformin therapy is gastrointestinal, GI, upset, which includes diarrhea, nausea, vomiting, abdominal bloating, flatulence, anorexia, and a metallic taste in the mouth. Such problems occur in approximately 30% of patients during the initiation of therapy and usually resolve with continued treatment. To minimize these adverse effects, treatment is started with a low dose and increased slowly at no less than weekly intervals. Because gastrointestinal upset is rare late in therapy, Any sudden onset of severe vomiting or diarrhea at that time should alert providers to the possibility of lactic acidosis, a rare but potentially fatal complication of metformin therapy. In such cases, patients should discontinue metformin immediately until they can be evaluated and stabilized. From data collected in Europe over 20 years, the reported worldwide incidence of metformin-induced lactic acidosis is 0.03 cases per 1,000 patient years. The risk of lactic acidosis increases with advancing age and worsening renal function. Therefore, metformin is contraindicated in patients with renal disease or dysfunction and acute or chronic metabolic acidosis. In addition, metformin should be temporarily withheld in patients undergoing radiologic studies requiring the use of iodinated contrast media because of their effects on renal excretion. Renal impairment is suggested in men with serum creatinine levels of 1.5 mg per deciliter or more and in women with levels of 1.4 mg per deciliter or more. Renal dysfunction may be secondary to a variety of comorbid conditions such as cardiopulmonary insufficiency, liver disease, alcoholism, and infection. These conditions predispose patients to impaired perfusion of tissues and decreased elimination of lactate and are therefore contraindications to the use of metformin. In addition, patients should temporarily discontinue metformin during any situation in which an acute decline in renal function may occur, e.g., aggressive diuresis, dehydration from gastroenteritis, surgery. The concomitant use of metformin with cimetidine increases the risk of hypoglycemia. The concomitant use of metformin with glucocorticoids or alcohol increases the risk of lactic acidosis. Next we will discuss thiazolidinedins. This class of anti-diabetic agents, as shown in Table 45.2, reduces insulin resistance at sites of insulin action. And now we will look at the mechanism of action of thiazolidinedins. Thiazolidinedins bind to the nuclear steroid hormone receptor peroxisome proliferator activated receptor gamma and increase insulin sensitivity in skeletal muscle and fat. Clinically, they decrease peripheral insulin resistance and at higher doses may decrease hepatic glucose production. Like biguanides, they improve the action of insulin without directly stimulating insulin secretion from the pancreatic beta cells. There is an improvement of endothelial function, preservation of beta cell function, and a decrease in albumin excretion. The patient's alanine aminotransferase (ALT) levels are monitored for possible hepatic toxicity every 2 months for the first year after the patient starts the drug and periodically thereafter. The patient must stop taking the medication if ALT levels are greater than 3 times the upper limit of normal. Hypoglycemia may develop in patients taking this class of drug with insulin or sulfonylureas because thiazolidinedins are potent sensitizers of insulin. If this occurs, the drug should be discontinued or the dose of insulin or sulfonylurea should be reduced. Pioglitazone, marketed as Actos, has been shown to increase HDL levels. Next we will discuss the adverse events and contraindications of thiazolidinedins. Pioglitazone may cause reduced concentrations of combined oral contraceptives. Therefore, patients using oral contraceptives should consider alternative contraception methods. The administration of rosiglitazone, marketed as Avandia, 4 mg twice daily had no clinically significant effects on the pharmacokinetics of combined oral contraceptives. In premenopausal anovulatory women with insulin resistance, ovulation may resume when drugs of this class are used. Thus, the patient may be at risk of unintended pregnancy, and contraception should be considered. Because of increased plasma volume from this class of drugs, thiazolidinedins are not recommended for patients with New York Heart Association Class 3 or Class 4 heart failure. Another contraindication is active liver disease. Thiazolidinedins can stimulate weight gain from plasma volume expansion and generation and redistribution of fats into the subcutaneous compartments. We will now progress to the alpha-glucosidase inhibitors. Let's discuss the mechanism of action of alpha-glucosidase inhibitors. The enzyme alpha-glucosidase, found on the brush border of the intestine, is necessary for the absorption of starch and disaccharides. This class of drugs, as shown in Table 45.2, acts by slowing the absorption of carbohydrates from the intestines, minimizing the postprandial rise in blood sugar. The result of this delay is decreased levels of postprandial glucose and HbA1c. The alpha-glucosidase inhibitors are most useful in patients with postprandial hyperglycemia and patients with very high HbA1c levels and poor dietary adherence. They are useful in patients from ethnic groups with high carbohydrate diets, such as Asians and Hispanics. Next we will look at the dosage of alpha-glucosidase inhibitors. Agents from this class can be prescribed alone or with a sulfonylurea. Patients should take each dose with the first bite of each meal. Dosages are increased gradually, at 4 to 8 week intervals, to avoid gastrointestinal side effects. The starting dose is 25 mg 3 times a day at the start of each meal. This regimen lasts for 4 to 8 weeks. Then the dose may be increased to 50 mg 3 times a day. After 3 months at 50 mg, the dose can be increased to 100 mg 3 times a day. Peak concentration occurs in 2 to 3 hours. And now we will consider contraindications for the use of alpha-glucosidase inhibitors. Acarbose, marketed as Precose, is contraindicated in patients with diseases of the bowel, e.g., inflammatory bowel disease, absorptive disorders, history of bowel obstruction, or cirrhosis. Patients with motility disorders of the upper gastrointestinal tract should not be treated with acarbose. Next we will discuss the adverse events and interactions of alpha-glucosidase inhibitors. The most common side effects involve the gastrointestinal tract. Increased fermentation secondary to the delay in carbohydrate absorption increases intestinal gas, causing flatulence, diarrhea, and abdominal distension. A 1-hour postprandial glucose measurement is useful to assess the therapeutic response during the dosage titration period. Additional monitoring should include serum aminotransferases every 3 months during the first year of therapy. Intestinal adsorbents such as charcoal antagonize this class of drugs. The alpha-glucosidase inhibitors may decrease the levels of propranolol and ranitidine. And now let's progress to the meglitinide analogues. Meglitinide analogues are rapid-acting insulin secretagogues that stimulate the release of insulin from the pancreas in response to a meal. See Table 45.2. Binding at characterized sites closes the ATP-dependent potassium channels in the membranes of the beta cells. This causes a depolarization of the beta cells and an opening of calcium channels. The resulting increased influx of calcium causes insulin secretion. Meglitinide analogues are effective in patients who become hypoglycemic while taking sulfonylureas and have acceptable fasting plasma glucose readings, but high postprandial blood glucose levels. They also are effective for patients with irregular meal schedules because patients take them at meals. Repaglinide, marketed as Prandon, and nateglinide, marketed as Starlix, are the 2 drugs available in this class. They lower postprandial blood glucose concentrations without any significant effects on fasting plasma glucose level. Meglitinide analogues can be used as monotherapy or in combination with other oral agents. The starting dose of repaglinide is 0.5 mg before meals if the HbA1c level is below 8.0. If the HbA1c concentration is greater than 8.0, the starting dose is 1 to 2 mg before meals. Patients must add a dose if they add another meal or skip a dose if they skip a meal. The dose may be doubled to 4 mg before meals to a maximum of 16 mg a day. Nateglinide is similarly administered with a starting dose of 60 to 120 mg before meals. The peak level is achieved in 1 hour. In 96 hours, the body excretes 90% of the medication. Meglitinide analogues are contraindicated in patients with diabetic ketoacidosis. Next we will discuss the adverse events of meglitinide analogues. Adverse events include hypoglycemia, gastrointestinal disturbances, upper respiratory infections, headache, diarrhea, constipation, arthralgias, and back or chest pain. Concomitant use with beta blockers or alcohol increases the risk of hypoglycemia. Ketoconazole, meconazole, erythromycin, and other cytochrome P450, CYP450, 3A4 inhibitors may potentiate the drug, as may nonsteroidal anti-inflammatory drugs, aspirin, sulfonamides, and warfarin. Drugs such as rifampin, barbiturates, thiazides, phenothiazines, phenytoin, sympathomimetics, calcium channel blockers, and isoniazid may antagonize it. And now we will progress to the dipeptidyl peptidase 4 inhibitors. Physiologically, in response to a glucose load, two incretin hormones, glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1, abbreviated as GLP-1, are released from the distal bowel. These hormones account for up to 50% of the response to postprandial glucose. However, dipeptidyl peptidase 4 inhibitors, abbreviated as DPP4, which is a surface enzyme, inactivates glucagon-like peptide 1, therefore decreasing the levels of circulating glucagon-like peptide 1 and glucoregulatory functions. The class of agents called dipeptidyl peptidase 4 inhibitors acts to block the effect against glucagon-like peptide 1 and ultimately increase the amount of native active circulating incretins. See Table 45.2. Currently there are only two dipeptidyl peptidase 4 inhibitors, sitagliptin, marketed as Januvia, and saxagliptin, marketed as Onglyza, on the market. Both medications are indicated for daily administration and co-administration with other oral antidiabetic agents. Sitagliptin is the only agent approved for use with insulin. We will now look at the dosage of dipeptidyl peptidase 4 inhibitors. Sitagliptin has one starting dose of 100 mg daily. Dosing should be decreased to 50 mg daily for patients with moderate renal insufficiency, defined by creatinine clearance greater than 30 ml per minute, but less than 50 ml per minute. Sitagliptin has also been pre-combined with metformin. The sitagliptin dose is 50 mg with either 500 or 1000 mg of metformin. It is also approved in combination therapy with sulfonylureas, thiazolidinedins, and insulin. Saxagliptin has two doses, 2.5 mg or 5 mg, also prescribed daily. The starting dose of 2.5 mg is used for patients with mild renal insufficiency. Saxagliptin is a strong CYP3A4/5 inhibitor. which interacts with other drugs that use that pathway. Like sitagliptin, it is approved for combination therapy with sulfonylureas and thiazolidinedins but not insulin. Next we will discuss the contraindications of dipeptidyl peptidase 4 inhibitors. The contraindications for both medications are similar and include hypersensitivity to the agent and type 1 diabetes mellitus. Caution should be used in patients with renal impairment. Only sitagliptin is contraindicated in the patient with a history of pancreatitis. And now we will look at the adverse events of dipeptidyl peptidase 4 inhibitors. The most common adverse effects are the same for sitagliptin and saxagliptin and include upper respiratory infection, urinary tract infection, and headaches when compared to placebos. Both drugs have potential for hypoglycemia when given in combination therapy with sulfonylureas. Additional post-marketing reports for sitagliptin include hypersensitivity reactions, such as anaphylaxis, angioedema, rash, urticaria, cutaneous vasculitis, and exfoliative skin conditions including Stevens-Johnson syndrome, hepatic enzyme elevations, and potentially fatal pancreatitis. Next we will discuss the interactions of dipeptidyl peptidase 4 inhibitors. Sitagliptin has no pharmacokinetic drug-drug interactions, but it pharmacodynamically potentiates the action of sulfonylureas and insulin. As a potent CYP3A4/5 inhibitor, saxagliptin interacts with drugs such as ketoconazole, erythromycin, and diltiazem. Let's now shift gears to incretins. This class is also called glucagon-like peptide 1. It is used as adjunctive therapy to diet and exercise in type 2 diabetes mellitus. The mechanism of action is to stimulate glucose-dependent secretion of insulin from pancreatic beta cells while suppressing the inappropriate release of glucagon from alpha cells. It slows gastric emptying, therefore increasing satiety. Fasting and postprandial glucose are reduced with the use of incretins. As euglycemia is approached, insulin secretion subsides, therefore avoiding hypoglycemia by the response of glucagon. Incretins are not a substitute for insulin, but augment the natural physiologic responses to elevated blood sugar levels. We will now discuss the dosage of glucagon-like peptide 1 analogs. Exenatide, marketed as Byetta, is only available as an injectable and can be used as monotherapy or in conjunction with other oral agents, metformin, sulfonylureas, or TZDs. Exenatide is not approved for use with insulin. The starting dose is 5 micrograms, injected over 60 minutes in the morning and evening or prior to the largest meals of the day and spaced more than 6 hours apart. Based on response, in 1 month the dose can be increased to 10 micrograms twice a day. The onset of action is within 1 hour and peaks in 2 hours. Next we will look at contraindications to the use of glucagon-like peptide 1 analogs. Exenatide is only contraindicated if the patient is allergic to known components of the drug. It should not be used in patients who have a history of pancreatitis or severe renal impairment. Caution should be exercised when using exenatide in those who have gastroparesis. There are a small number of cases in which patients develop antibodies or immunogenicity to the drug. Alternative therapy should be considered if this occurs. Next we will discuss the adverse events of called glucagon-like peptide 1. The most common adverse reactions to exenatide are gastrointestinal related, including nausea, vomiting, diarrhea, and dyspepsia. Hypoglycemia is also a concern when exenatide is prescribed in combination with a sulfonylurea. Caution should be exercised with any dose increase to monitor for signs and symptoms of pancreatitis, especially severe abdominal pain with or without vomiting. Exenatide should be stopped immediately with any of these signs. Interactions due to the decrease in gastric emptying. Exenatide should not be administered close to drugs that have a narrow therapeutic window. Caution should be exercised when patients are taking warfarin, and the international normalized ratio should be monitored closely with drug initiation and dose changes. Exenatide can possibly decrease in the ethinyl estradiol component of oral contraceptives. Therefore, exenatide and oral contraceptives should not be administered within 1 hour of each other. Next we will discuss pramlintide acetate. This is a new, injectable agent that is a synthetic of the pancreatic neurohormone amylin, which is co-secreted with insulin from beta cells in response to food. Pramlintide has 3 actions as an amylinomimetic agent. First, it helps to delay gastric emptying into the small intestine, which delays the rise in postprandial glucose release. This effect lasts for approximately 3 hours and does not alter nutrient absorption. Second, pramlintide alters the release of additional inappropriate glucagon by pancreatic alpha cells, which is abnormal in diabetes mellitus. Finally, there is an increase in satiety, which decreases the total calorie intake and promotes weight loss. Pramlintide can be used to treat type 1 or type 2 diabetes mellitus. Unlike exenatide, it is approved for use with insulin. And now we will look at the dosage of pramlintide acetate. The initiation and dosage of pramlintide differs for type 1 and type 2 diabetes mellitus. However, the management of changes in dosage, side effects, and monitoring blood sugar levels is the same for both. The starting dose for those with type 1 diabetes mellitus is 15 micrograms just prior to any major meal. If tolerated, pramlintide is titrated by 15 microgram increments to a total dose of 30 to 60 micrograms. Patients with type 2 diabetes also administer pramlintide just prior to any major meal at 60 micrograms per injection. The dose is increased to 120 micrograms in 3 to 7 days if there is no nausea. Both patients with type 1 and type 2 diabetes mellitus must reduce their current insulin regimen by 50%. The titration of pramlintide is based on blood glucose levels and the presence or absence of nausea. Close monitoring of blood glucose levels is very important to detect hypoglycemia. If significant nausea occurs, the dosage should be decreased until the drug is tolerated. If nausea persists even at the lowest dose, pramlintide should be discontinued. Next we will discuss the contraindications for the use of pramlintide. Few physiologic contraindications exist for those whom pramlintide is appropriate. However, it is critical to select appropriate patients. Those with poor adherence to diabetic care regimens, those with HbA1c greater than 9%, those taking drugs that increase gastric motility gastroparesis, and pediatric patients should not take pramlintide. Additional precaution exists for anyone with known hypersensitivity to the product. Studies have shown no effects on the drug in those with renal or liver disease and are approved as safe. Let's now focus on the adverse events of pramlintide. The most common side effects include nausea, vomiting, headache, and anorexia. The only serious side effect can be hypoglycemia. And now we'll look at the interactions of pramlintide. Delayed absorption of other medications can occur. Pramlintide should be administered at least 1 hour before or 2 hours after other medications. Pramlintide has not been officially studied with oral antidiabetic agents. We will now switch gears to insulin. Insulin is the drug therapy of choice for all patients with type 1 diabetes mellitus and those patients with type 2 diabetes mellitus, who cannot control their condition with diet and exercise alone or in whom oral therapy fails. Other clinical situations in which insulin therapy is appropriate include newly diagnosed cases of type 2 diabetes mellitus presenting with severe, symptomatic hyperglycemia, pregnancy, and surgery. Just like the insulin that the pancreas normally produces, insulin as drug therapy regulates glucose metabolism in the muscle and other tissues, except the brain. It causes the rapid transport of glucose and amino acids intracellularly, promotes anabolism, and inhibits protein catabolism. In the liver, it promotes the uptake and storage of glucose in the form of glycogen, inhibits gluconeogenesis, and promotes the conversion of excess glucose into fat. The major characteristics of insulin preparations are onset of action and duration of action, as shown in Table 45.4. Semisynthetic insulin, which is produced by recombinant deoxyribonucleic acid technology, has the identical amino acid composition as human endogenous insulin and is therefore referred to as human insulin. Human insulin preparations lower the risk of local reactions. An insulin analog, lispro-insulin, is a 2-amino acid modification of regular human insulin. Aggregates do not form when lispro-insulin is injected subcutaneously, allowing for a more rapid onset and shorter duration than regular insulin and minimizing the postprandial rise in blood sugar and the risk of late hypoglycemia. Another human insulin analog is insulin glycine. Insulins are categorized as basal, e.g. neutral protamine hagedorn abbreviated as NPH, lente, glargine, and detamere, or bolus, regular, lispro, and aspart. Initial insulin doses should be individualized in patients previously untreated with insulin. Preferably, a therapy with a basal insulin plus a bolus insulin 15 minutes before each meal is started. A minimum of 2 daily injections, also called a split-dose regimen, should be considered to achieve regulation of blood glucose, especially in patients with type 1 diabetes. A common regimen is injection of a mixture of an intermediate-acting insulin, e.g. neutral protamine hagedorn, NPH, and rapid or short-acting insulin twice a day, 15 minutes before breakfast and 15 minutes before dinner. Usually, patients take a 2-to-1 ratio of neutral protamine hagedorn to rapid, short-acting insulin before breakfast and a 1-to-1 ratio before dinner. Patients take 2/3 of the total daily dose in the morning and 1/3 in the evening. However, a more physiologic way to administer insulin is to inject a basal insulin, glycine or detamere, at least daily, but it can be twice a day. Additional bolus doses of short-acting insulin, preferably lispro, are administered just prior to each meal. This type of regimen can be used in patients with type 2 diabetes mellitus, who require insulin and are not on oral anti-diabetic agents. It is a preferred method for most patients with type 1 diabetes mellitus who require 3 to 4 injections a day for optimal control. Table 45.5 lists various insulin regimens. Pause the video and carefully scrutinize Table 45.4 summarizing insulins before proceeding to the next slide. We will now discuss the dosage of insulin. To start insulin in patients with type 2 diabetes mellitus, an evening dose of 10 units of basal insulin is started. Additional doses are added based on the fasting plasma glucose as follows. 1. 2 units if fasting plasma glucose is above 120 mg per deciliter. 2. 4 units if fasting plasma glucose is above 140 mg per deciliter, and 6 units if fasting plasma glucose is above 180 mg per deciliter. Insulin doses should be individualized and closely monitored. In lieu of empiric estimations, however, the following guidelines can be used for total daily dosing. 1. In children and adults, 0.5 to 0.6 units per kilogram per day. 2. In adults during illness or adolescence, 0.5 to 0.75 units per kilogram per day. 3. In adolescents during a growth spurt, 1.25 to 1.5 units per kilogram per day. And 4. During pregnancy, 0.7 units per kilogram per day. If 2 doses are given a day, it is recommended that 2/3 of the total daily dose be given in the morning with a 2-to-1 ratio of intermediate to short-acting insulin, and 1/3 of the total daily dose be given before dinner with a 1-to-1 ratio of short-acting insulin and intermediate-acting insulin. Doses should be adjusted based on the patient's clinical response, as evidenced by blood glucose levels. Adjustments are made in 1 to 2 unit increments. Insulin must be decreased with hypoglycemia and increased with hyperglycemia. Table 45.6 provides some suggestions on when dosages need adjusting. For information on time frame for response, see Table 45.4. Use of insulin is contraindicated with hypoglycemia. Insulin glargine is given at bedtime and cannot be mixed with other insulins. The 1500 rule can be used to determine the change needed in the insulin dose. The insulin sensitivity factor, abbreviated as ISF, is determined by dividing a constant, 1500, by the total daily dose, abbreviated as TDD, of insulin. This determines the change in blood glucose from 1 unit of insulin. The formula is insulin sensitivity factor is equal to 1500 divided by the total daily dose. For example, if the patient takes 50 units of insulin in 24 hours, the insulin sensitivity factor is 1500 divided by 50, which translates to 30. Therefore, each unit of insulin lowers the blood glucose level 30 mg per deciliter. If the self-monitoring blood glucose at noon is 170, an addition of 2 units in the morning should lower the blood glucose level to 110 mg per deciliter. We will now consider the adverse events of insulin. Hypoglycemia, hyperkalemia, lipodystrophy, and local or systemic allergic reaction can occur with insulin. The dawn phenomenon, so called for worsening hyperglycemia that occurs in the early morning hours, is caused by growth hormone surges that occur during sleep. The Somogyi effect, which also may be mistaken for inadequate control, is a rebound of hyperglycemia that occurs after an early morning episode of insulin-induced hypoglycemia. The hypoglycemia goes unnoticed because it happens while the patient is sleeping, at approximately 3 a.m. Assessment clues include night sweats, nightmares, sleep disturbances, and early morning headaches. Monitoring of blood glucose when hypoglycemia is thought to be occurring helps make the diagnosis. Let's now focus on the interactions of insulin. Salicylates, beta blockers, monoamine oxidase inhibitors, alcohol, and sulfur drugs potentiate insulin. Corticosteroids, isoniazid, niacin, estrogens, thyroid hormones, thiazides, phenothiazines, and sympathomimetics antagonize it. Pause the video and carefully scrutinize Table 45.5 summarizing various insulin regimens before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.6 summarizing adjusting insulin dosages based on clinical response before proceeding to the next slide. We will now discuss special considerations. Let's begin with the pediatric and adolescent populations. Until the mid-1990s, Type 1 diabetes mellitus was the prevalent type of diabetes in children and adolescents. Recently, 40% of newly diagnosed cases of diabetes in children ages 10 to 19 have been type 2 diabetes mellitus. The greatest risk factor is childhood obesity. Diabetes mellitus is often discovered with glycosuria on a random urinalysis. A red flag for type 2 diabetes mellitus in adolescents is acanthosis nigricans, dark pigmentation in skin creases and flexural area. This is a sign of insulin resistance and is present in 60% to 90% of adolescents with type 2 diabetes mellitus. Hypertension is present in 20% to 30% of adolescents with type 2 diabetes mellitus. In type 1 diabetes mellitus, children present with inappropriate polyuria, dehydration, poor weight gain, and ketonuria. Treatment for type 1 diabetes mellitus in children is insulin therapy. Doses are as listed below. 1. 0.7 mg per kilogram before puberty. 2. 1.0 mg per kilogram mid-puberty. And 3. 1.2 mg per kilogram after puberty. These children should be treated by a specialist. Treatment for type 2 diabetes mellitus: weight loss, medical nutritional therapy, exercise, and in many cases, medication. The only drugs approved for adolescents are insulin and metformin. Next we will look at the geriatric population. Diabetes mellitus in the elderly is often complicated by coexisting conditions. Complications develop at an accelerated rate probably because poor glycemic control has been long-standing. Also, the elderly usually have a decrease in renal function. Exercise programs for the elderly have to be started carefully with comorbid conditions in mind. And now we will consider pregnancy. There are two types of diabetes during pregnancy. One is pregestational diabetes, present before the pregnancy. This is treated by a specialist during pregnancy and is considered very high risk. The most common is gestational diabetes, which is glucose intolerance detected during pregnancy and associated with probable resolution after pregnancy. Experts now believe that high-risk women found to have diabetes at pregnancy should be diagnosed with overt diabetes, not just gestational diabetes. During pregnancy, human placental lactogen plays a pivotal role in triggering glucose intolerance. It has an anti-insulin and lipolytic effect. Peripheral insulin sensitivity decreases to 50% of the first trimester during the third trimester. Basal hepatic glucose output increases by 30%. Screening is recommended between weeks 24 and 48. The recommended test is the 50-gram 1-hour glucose screening test, although some women require a 3-hour glucose tolerance test. In the gestational diabetic, multiple daily self-monitoring blood glucose are required, and it can often be controlled by diet and medical nutritional therapy. If this does not control glucose levels, insulin is required. Potential neonatal complications include shoulder dystonia, hypoglycemia, polycythemia, and respiratory distress. Pause the video and carefully scrutinize Table 45.7 summarizing the capacity to decrease HbA1c by agent before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.8 summarizing the recommended order of treatment for type 1 diabetes mellitus before proceeding to the next slide. Pause the video and carefully scrutinize Table 45.9 summarizing the recommended order of treatment for type 2 diabetes mellitus before proceeding to the next slide. Next we will discuss selecting the most appropriate agent. Insulin is necessary in all cases of type 1 diabetes mellitus. In patients with type 2 diabetes mellitus, various oral agents as monotherapy or in combination therapy can be prescribed, because the oral agents act in different ways. Table 45.7 lists the potential decrease in HbA1c with each agent. Table 45.8 shows first and second line for patients with type 1 diabetes mellitus. Table 45.9 shows first, second, and third line therapy for patients with type 2 diabetes mellitus, as shown in Figure 45.1. Let's now consider first line therapy. In type 1 diabetes mellitus, insulin is the first line therapy. It usually is administered in a combination of intermediate and short-acting insulin. The dosage is 0.5 to 0.6 units per kilogram per day. Several schedules can be used for administering insulin. See Table 45.5. The most common regimen is 2 injections a day, one in the morning and one in the evening. This promotes glycemic control during the day and while the patient sleeps. The insulin dose required is divided into 2/3 of the dose in the morning and 1/3 of the dose in the evening. The morning dose is divided into 2/3 intermediate insulin and 1/3 short or rapid-acting insulin. The evening dose is 1/2 intermediate insulin and 1/2 short or rapid-acting insulin. First-line therapy for type 2 diabetes mellitus is monotherapy with an oral agent. The agents used for first-line therapy are sulfonylureas, biguanides, thiazolidinedins, alpha-glucosidase inhibitors, and meglitinates. They act in different ways. The rule for initiating therapy with any of these agents is to start slowly and increase the dose every 1 to 2 weeks as needed. If intensification of treatment is required to meet goals, i.e., HbA1c below 7.0%, the addition of another drug from a different class is recommended. Sulfonylureas are the best choice if the patient has a blood glucose level over 250 mg per deciliter and is thin. Biguanides and thiazolidinedins are the drugs of choice in patients with metabolic syndrome. The alpha-glucosidase inhibitors are most effective in patients with postprandial hyperglycemia but only mild fasting glucose elevations. Regarding second-line therapy with failure to achieve optimal blood glucose levels in type 1 diabetes mellitus, practitioners must gradually increase the insulin dose, making adjustments 1 to 2 units at a time over 3 days. They must base adjustments on self-monitoring blood glucose records. Table 45.10 lists how to determine adjustments. Failure to achieve optimal blood glucose levels in type 2 diabetes necessitates the addition of another oral agent. Combinations of sulfonylureas and biguanides, thiazolidinedins, or alpha-glucosidase inhibitors are effective. Insulin may be added to oral medication regimens for effective control. Insulin is started at the lowest dose and increased every 1 to 2 weeks as needed. Let's now look at third-line therapy. In patients with type 1 diabetes mellitus, clinicians should add a thiazolidinedione or metformin to the regimen of insulin if control is still poor. They may add an alpha-glucosidase inhibitor if postprandial blood glucose is high. Patients with type 1 diabetes may be appropriate candidates for an insulin pump. In patients with type 2 diabetes mellitus, insulin is added if the addition of a second agent and third agent is unsuccessful. An intermediate or a basal insulin at bedtime added to the daytime oral regimen can be very effective in treating those with type 2 diabetes mellitus to goal. Let's now briefly discuss combination therapy. The following are suggestions for combination therapy for type 2 diabetes mellitus. 1. A sulfonylurea and a biguanide produces mealtime stimulation of endogenous insulin with the sulfonylurea and gluconeogenesis with the biguanide. This is recommended for HbA1c level above 8%. 2. A sulfonylurea and a thiazolidinedione improves insulin resistance, and may enable a decrease in the sulfonylurea dose. 3. A biguanide and a thiazolidinedione combination provides a synergistic effect on glycemic reduction. Liver and renal function must be monitored with this regimen. 4. Alpha-glucosidase inhibitor and another agent are best used with an elevated postprandial blood glucose level. 5. Meglitinide and a thiazolidinedione or biguanide combination promotes a stimulation of insulin release and a decrease in peripheral insulin resistance and fasting hyperglycemia. Next we will discuss monitoring patient response. Prolonged hyperglycemia of diabetes gives rise to long-term complications that involve lesions of the small, that is microvascular, and large, that is macrovascular, blood vessels. Microvascular complications include retinopathy, nephropathy, and neuropathy. Control is measured using the patient's levels of blood glucose and HbA1c. Patients use self-monitoring blood glucose to keep a daily record of blood glucose. HbA1c measures blood glucose over 3 months. Table 4510 lists the desired levels and levels that require changes in drug regimen. Pause the video and carefully scrutinize Figure 45.1, which is an algorithm for pharmacotherapy for type 2 diabetes mellitus, before proceeding to the next slide. Let's now progress to patient education. We will begin with drug information. Education is a hallmark of diabetes therapy. Self-monitoring blood glucose is essential for monitoring therapeutic response. Practitioners must educate patients about the signs and symptoms of hypoglycemia and instruct them to carry a source of glucose with them at all times. Possible sources are hard candy, not sugarless, or 4 ounces of orange juice. All patients with diabetes should have medical identification in the form of a Medic Alert bracelet or necklace. In patients taking insulin, meals are to be eaten on a regular basis. If a rapid-acting insulin is used, it is taken immediately before eating. The alpha-glucosidase inhibitors are only taken if a meal is eaten. Here are some patient-oriented sources for information. 1. www.diabetes.org is the site from the American Diabetes Association with information for managing the diabetic's life. 2. www.niddk.nih.gov/health/diabetes.htm is a site from National Institutes of Health that serves as an information clearinghouse. 3. www.diabetes.com provides information for the diabetic individual. Pause the video and carefully scrutinize Table 45.10 summarizing measures of control of fasting blood glucose before proceeding to the next slide. Next we will discuss nutritional and lifestyle changes. Diabetes management includes medical nutrition therapy, exercise, and, in most cases, drug therapy. Foods high in processed sugar and fat are to be avoided, as is alcohol. Regular daily exercise helps to control blood sugar levels. Patients with diabetes must follow sick day guidelines for the treatment of their condition when dealing with other illnesses. In general, Practitioners should instruct people with diabetes not to stop their medication when they are ill. Infection, stress, and other variables increase plasma glucose levels, even though oral intake may be reduced. Practitioners should instruct patients to increase their fluid intake to approximately 8 ounces of water or sugar-free beverage every hour, especially if they have a fever. Patients should monitor blood glucose levels at home more frequently, as often as every 4 hours. Urine also requires testing for ketones. If the blood glucose concentration is greater than 300 mg per deciliter on 2 consecutive readings, fever is persistently high, and symptoms of severe dehydration and ketonuria develop, the patient requires formal evaluation. Sick day plans should be developed with patients before illness occurs. Finally, we will look at complementary and alternative medicine. In a recent study conducted at the U.S. Department of Agriculture, cinnamon reduced serum glucose levels and improved lipid profiles in patients with type 2 diabetes mellitus. Patients were randomized into 6 groups that received 1, 2, or 3 grams of cinnamon or a placebo. All groups receiving cinnamon had a decrease of 18% to 30% in fasting serum glucose values and a reduction of 23% to 30% in triglycerides and 7% to 27% reduction in LDL levels. Total cholesterol level declined 12% to 26%. A daily vitamin is recommended if the patient is on a weight reduction plan. Next we will discuss sinusitis. Sinusitis is an inflammation and/or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically also involves the nasal mucosa. The majority of these infections are viral in origin, nevertheless, antimicrobials are prescribed frequently. It is thus important to differentiate between viral and bacterial sinusitis to aid in optimizing treatment decisions. Viral sinusitis and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. Acute disease lasts less than 30 days with complete resolution of symptoms. Chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Sinusitis is diagnosed more frequently in children than in adults. Typical clinical presentation and diagnosis of bacterial sinusitis are illustrated in Table 107-4. Between 5% and 13% of viral upper respiratory tract infections in children are complicated by bacterial sinusitis, whereas only 0.5% to 2% of viral upper respiratory tract infections in adults are complicated by sinusitis. Factors associated with the development of bacterial sinusitis include viral respiratory tract infections and, less commonly, allergic inflammation. Other factors that can be associated with sinus disease include systemic diseases, trauma, environmental exposures, and anatomic abnormalities.